The appropriate balance between individual and societal responsibility for the coverage of medical expenses is dependent more on whether healthcare is considered a right or a privilege than the social model used to examine the question. Whether using Rawls' veil of ignorance or conceding that America is composed of rugged individuals and social contracts exist in very limited circumstances, as is the atomist view, the support of a right is much more robust than the availability of a privilege. Furthermore, if we curtail access to a right or privilege, but especially a right, because of an individual's choices, then we are left with the uncomfortable question whether those choices are truly a product of unfettered free will or easily traceable to the constrictions imposed by societal or constitutional causes. Healthcare is expensive, and there are few occurrences in a life that affect an individual more intimately than the outcome of an illness. And so, any discussion of healthcare is fraught with emotion. Perhaps it is more enlightening to examine the curtailment of access to a right or a privilege not so intimate as healthcare. Consider driving, universally regarded as a privilege, versus voting, generally thought of as a right. The most adamant proponent of Rawls' concept of fairness would likely agree that while all should have access to the privilege of driving, that privilege is subject to appropriate behavior and a requirement to demonstrate basic competence of the task. Put more simply, yes, everyone should have access to driving because it is necessary to function in this country. But you must pass a driving test, and you can't habitually drive recklessly or under the influence of alcohol. The atomist and the Rawlsian may differ on what access means, but would likely agree on the general principle that individual responsibility carries the day on the maintenance of the privilege. The most ardent atomist would agree that the individual must enter the social space in helping to choose the political leadership of the country, and as such, that entry should be broadly available and subject to the least restriction. Where the two schools of thought may differ is the social responsibility to ensure that broad availability, but that it should exist unfettered, is a fundamental American ideal. Is healthcare a right? More fundamentally, how do we decide if something is a right? A right is enshrined in a legal framework and considered essential for participation in society. The right to life is acknowledged in the foundational document of this country. Healthcare is fundamental in many circumstances to maintaining life, and the maintenance of health is fundamental for the capacity to participate in society. Logically, healthcare is a right. The more rugged of our individuals may be unconvinced, and to them more evidence can be offered that their fellow citizens have implicitly placed healthcare in the legal framework of a right. Roughly 40% of Americans have governmental insurance coverage. American employers with greater than 50 employees are mandated to provide insurance. Hospitals are legally obligated to treat all emergency patients regardless of insurance status. Nearly all children have mandated coverage for vaccination, and 96% of children nationally have mandated insurance coverage. Thus, independent to its association with right to life, by virtue of its essential nature for societal participation and the diverse laws that enshrine its access, healthcare is a right. And regardless of the philosophical framework used, we have a legal and ethical history that seeks to extend access to that which we consider a right despite individual behavior or characteristics. To extend the analogy once again to voting, we don't take away the right if the individual doesn't have a certain IQ or fund of knowledge or hasn't voted in many elections, demonstrating over time a disinterest in governance. Though controversial, many jurisdictions even allow prisoners and ex felons to vote. Similarly, we cannot impose a financial penalty on healthcare because of an individual's behavior if that penalty effectively takes away the right to health and, in the worst case scenario, the right to life. This is not to say that there is not some devil in the details. Under the assertion that healthcare is a right, if a smoker develops lung cancer, his care should not cost more than such that the cost effectively becomes denial of care. This doesn't mean that his insurance premiums can't be higher because his behavior, by virtue of the potential of future healthcare costs to society, merits some responsibility. This is not equivalent to denial of care. The extent of that responsibility, that is, the increased cost of his premium, is an argument that the Rawlsian and the atomist can have in the political arena while ensuring that the increased burden doesn't effectively deny him access to the right to health care and, by extension, the right to life. That argument must be tempered by the consideration of what is meant by responsibility, or more precisely, the consideration of the intersection between a freely chose course of action versus one that is heavily influenced by the impositions of a societal past or an inherent individual characteristics. Unequivocally, smoking and the use of tobacco in general are detrimental to health and increase healthcare costs. Its dangers are broadly known and broadly accepted. It is therefore the low hanging fruit of assigning behavioral responsibility to healthcare costs. Why do 20% of Americans still use tobacco products? The main reasons include a stronger genetic propensity to nicotine addiction, a greater susceptibility to marketing early exposure, leading to an alteration of brain structure and stress relief due to nicotine's close association with dopamine. There is a high correlation with smoking and socioeconomic status. Is it just to charge an individual a greater healthcare premium for having a genetic propensity for engaging in a habit that altered his brain as a minor, for developing a habit that occurred in the first place because society refused to eliminate the marketing of a deadly product with no redeeming value, and for a lack of access to a robust mental health system? The rugged individual may say yes, but the question will hopefully temper the extent of the penalty and maintain the social contract of providing health care as a right. What about obesity? Perhaps only second to tobacco use, it is broadly acknowledged as a source of rising healthcare costs. How do we assign individual responsibility? Do we charge more and more for each incremental rise of BMI over 25? How do we account for genetic and racial differences for muscle versus fat ratio or for lack of access to nutritious food? And if we have such difficulty in assigning responsibility for relatively straightforward parameters such as tobacco use and weight, how can we possibly assign responsibility for more controversial and difficult to measure behaviors such as lack of exercise or risk taking? Healthcare is expensive, complicated, and fundamentally a right. Because it's complicated and expensive, it is tempting to introduce the concept of individual responsibility to curtail and shift its costs. It is particularly tempting for those who view social contracts in general as necessary evils. However, when examining the ethical and scientific quagmire that results from trying to fairly assign costs for individual behavior. It may be more honest to concede that if healthcare is a right, then its access should be unfettered as possible and its cost nearly equitable regardless of behavior.